the title here is quite strong. Minimally invasive CO2 removal may substitute high flow ECMO. Everybody may say, okay, you are crazy. If you look at the last ASIM guideline for RDS, is written on the basis of the Veolia study that ECMO in certain degrees of oxygenation and so on is highly recommended, while the CO2 removal, please forget it, is maybe has to be studied, just a randomized study, cannot be even thought to be used in RDS, severe RDS. Is that true? Well, let's discuss a little bit. Let's see. There is no doubt that ECMO was invented, was proposed to control the oxygenation, extracorporeal membrane oxygenation. CO2 is ignored because, you know, in the 70s, when we start with ECMO, and the ECMO is the only way to substitute the alveolar capillary function. And the problem was the oxygenation, no? And so all the studies, no? From the first study was from Zeppel in end of the 70s. You know, the PO2 lower than 50 for 2 hours with P5, fast entry. PO2 lower than 50 for 12 hours, FiO2 P5 or shunt, we were measuring the shunt, greater than 30. Then, Alan Morris in 94, similar criteria of this. The Caesar trial had a Murray score, which included oxygenation, but look at the Olja trial. The Olja trial is the one which is maximum 9, or is the reference point. Here, PF lower than 50 for at least 3 hours, PF lower than 80 for at least 6 hours. Very similar to this one. They're about almost 40 years along, these two. But there is no doubt that oxygenation is the main indication for ECMO. With the ECMO in venous, we charge the venous blood with a lot of oxygen. The blood goes into the lung, which is near fully oxygenated. The oxygen transfer through the natural lung is very low because the hemoglobin is almost saturated, when the PO2 is decently high in the arterial side. Good. Now, don't look here. Look at this one. PO2 and PEEP. There is blue and red. Which are the ECMO patient and which are the control? Look here. Baseline, similar. Here, it's hard to see any difference. So if the problem is oxygenation, how happens that the control have exactly the same oxygenation than the treated with the same PEEP? But look at the PaCO2. It's clearly far higher here than here. That means the ECMO on gas exchange, what really allowed to change was the PCO2. The PCO2 is a sign of what? It's a sign of the minute ventilation. Minute ventilation is the cause of the ventilator-induced lung injury. So if we look from a different perspective, what is irrelevant to correct the ventilator setting is the possibility of take out the CO2 from the blood. The oxygen doesn't make any great difference. It is unbelievable that usually the people doesn't speak about that, which is absolutely evident even in the reference study, which is the earlier study. And if we look at the earlier physiological variables, you see PaCO2, of course, we have seen is different, but the plateau pressure was 24, about 5-6 points lower. The driving pressure was definitely lower at the beginning of the treatment. That means even in the earlier, what changed was the way of ventilate the patient, not the way of oxygenate the patient. Starting with that, they say, well, if I remove the CO2 without oxygenation, if the oxygenation is not important, I should have the same possibility to correct my ventilation without providing a lot of damage. And maybe let's see how the oxygenation goes. So this is a key question. Why still are used the entry criteria, the oxygenation? If when I oxygenate, at the end of the story, control and treated are behave exactly in the same way. So this is the earlier trial. By the way, it's not significant, but everybody believes that the ECMO is good. So the behavior around the mode, the fashion, and the people say, okay, this is the the best negative or the most positive trial between the negative trial of something like that. But still, because the number of believers in ECMO increase compared to the numbers of non-believers. If you look in a very aseptic way, the earlier trial was interrupted for futility. That means even go ahead with the scheduled number of patients was impossible to reach the magic 0.05. Then after that you can, but it was 0.07, I mean, which is not bad at all. So the people which is used to ECMO knows that the ECMO or the extracorporeal support is a powerful instrument. But how to do what? Yeah, provide oxygenation or to decrease the ventilator-induced lung injury through the CO2 effect, not the oxygen effect. The basic of ECMO versus ECO2R are summarized in this slide. This is a mixed venous blood, no? And to oxygenate, let's see, and to provide 250 milliliters per oxygen consumption, I need in this condition 7 liters in the lung, pulmonary blood flow. My PO2 will be 100, saturation 98 if I provide. And the ventilation, I don't need any ventilation if I keep the PCO2 constant. I can just give a cannula with 250 milliliters of oxygen per minute. To oxygenate, I don't need ventilation if the PCO2 is controlled, but I need a lot of blood flow. For CO2 removal, I don't need a lot of blood flow because the CO2 content in the venous blood is quite high. It's 52 milliliters per 100. Oxygen is far less. Okay? So for CO2 removal, I need a lot of ventilation to excrete or to clear to other milliliters. So with the membrane lung, I can dissociate these two functions. I can use the membrane lung for oxygenate ECMO, or I can use the membrane lung basically for CO2 removal. Of course, if I have a very low flow in a membrane lung, I cannot oxygenate because the flow is too low to oxygenate this. So we went to design a study in which we had 24 pigs. Was quite rather complicated study. And we had two models of injury. 12 pigs underwent a direct lesion into the lung through the intratracheal chloride acid. This was just to simulate the primary RDS. Another group, we were trying to simulate the extrapulmonary RDS, giving oleic acid. Oleic acid give you, is done through the blood, goes, all the lung is exposed, while to the intratracheal, chlorine goes in some part of the lung, some part is spared, and this is more complete venous lesion diffusion, and it basically is a big damages to the alveolar capillary endothelial membrane. So we have edema and so on. Then we have only two pigs that didn't undergo any extracorporeal circulation. Then we have the patient which were treated with ECMO had the blood flow 50-60 milliliter per kilo. We were using about 50-60 kilo pigs. That means was a quite high blood flow. And the ECO2R was 400 milliliters. That means 50 to 400 was almost nothing, no? Compared to the other one. So we compare these two groups: ECMO, high flow ECMO, 50 milliliters, then 50 milliliters per kilo, versus a flow of less than 1 milliliter per kilo. Now, which was the difference? We have a quite huge difference. At the baseline, the group was similar, not to the basic before induction of injury. After the injury, it came out that oleic acid was more affected in terms of oxygenation injury. The plateau pressure was higher in the chlorine, stress was higher in the chlorine, extravascular lung water was far higher in the oleic acid, and the wedge pressure was higher in the chlorine. So our two models were quite different, because one, the lung is more humid, more wet. The other one, the lung is more dry, but the lung mechanics are a little bit worse than in oleic acid. So these are the baseline, and these are the hydrochloric acid and oleic acid injury in ECMO and in ECHO and without treatment. You saw ECHO and without treatment, the VO2 along the course of the experiment was definitely higher, or similar oleic and hydrochloric, but definitely higher than the VO2 in ECMO group. And you can say, was higher or was normal? You know, at the beginning, they were similar, quite low here. Then here we have the media stress. This one goes down. This one remains quite elevated. Of course, if we speak about CO2 removal, if we have far higher VCO2, the baseline for the same VCO2 removal on the membrane line, the PCO2, the total clearance is different. Now, carbon dioxide. The total VCO2, you see once again, is quite higher here in the hydrochloric acid, in oleic acid, in X2R versus ECMO. So there is no doubt that if I provide oxygen through the membrane line with high flow, compare not providing oxygen, but just removing the CO2, the overall metabolism is affected. There are possible different explanations. We are not sure about what is the most relevant, but different there are. But what about the PO2? You are hydrochloric acid treated with ECMO, treated with ECHO. And you see that are almost just by the 1 hour different, then are in a sense indistinguishable. And look also the absolute values. Here you have 100 of PO2 in ECHO. And in ECHO, we were changing the ventilation in this animal according to try to provide a possible greater lung rest, oxygenating in terms of mechanical ventilation. The arterial oxygen saturation. So we are over 90. Oleic injury takes more time, but once again, with the saturation after 6-7 hours, the saturation was similar. So the oxygenation was not dramatically different between the two. We had one thing which was quite different. There is no doubt that in X2R, extracorporeal removal, low flow, the pulmonary vascular resistances were definitely higher in ECHO, while were far more controlled with ECMO. So we had, with these resistances, you had to sustain with cardioactive drugs the system more with extracorporeal removal than with ECMO. And this is respiratory elastance. So the hemodynamic was worse with ECHO than with ECMO. And what's about the respiratory elastance? It's much, much worse in ECMO, in both hydrochlor and both oleic acid injury. That means with the hemodynamic benefit, but with the kind of the treatment we use in mechanical ventilation, so reducing the mechanical ventilation in the ECMO group, caused the lung to progressively collapse and to elastance progressively increased. Okay, in this last slide, we try to summarize some of the contradiction we found in this study, because we are looking to the physiological variables. But now the changes in physiological variables observed, I think, depends on 3 factors. One depends by the model. That means use of chloride acid versus oleic acid. One, it depends by the technique, using of ECMO compared to using of X2R. And the third, depend the operator, using protective mechanical ventilation or ultra-protective mechanical ventilation. Our result is a sort of collection of these three factors. Let's see. Let's try to summarize. We know that due to the difference in lesion, primary RDS, we have less severe hypoxemia because part of the lung is saved. We have lower edema, about 1/3 of the edema compared to the other one, and we have high hypoxic vasoconstriction. When you put oleic acid, we have more severe hypoxemia because you have more edema, and we still have high hypoxic vasoconstriction. Pulmonary artery is very high, resistances are not very different from this and this. But then we use the difference due to the technique. And the technique here with ECMO, we increase a lot the amount of oxygen going into the venous system, going to the lung. Here, we don't add any oxygen practically, 10 milliliters, 5 milliliters per minute. So we have increased SVO2, lower SVO2. This leads to the abolition with ECMO of hypoxic vasoconstriction, and we have a favorable hemodynamics because we have preserved the hemodynamics, and this is not clear. It depends from many things, but I think it's quite important. We have a lower, not maintained, lower VO2 and lower VCO2. With echo, we have a lower SVO2, so we maintain the hypoxic vasoconstriction, which helps for oxygenation, but the hemodynamics are very compromised because with the lesion, with the model we use, here we do not correct anything. We leave the hemodynamics as they are, and these are the higher VO2 and VCO2. So for the same removal of a VCO2, we have, here we remove almost 80%. We remove 50% of the CO2, of the CO2 produced. And then we have how the doctor react. If the doctor say, okay, well, oxygenation is good, everything is good, I decrease the mechanical ventilation. And I decrease the mechanical ventilation in a protective way during echo to air, because I still have to eliminate a lot of VCO2 because the production of CO2 was for higher. So here we have protective mechanical ventilation, 6 and so on. Having protective mechanical ventilation, the lung mechanics were good. If I use ultra protective mechanical ventilation, 4, 3, and so on, it's a disaster in terms of lung mechanics, because the lung progressively collapsed because of reabsorption of telectasis, lung collapse, and finally increased elastance. And you may say, okay, but the heart study, the rest study, excuse me, showed that echo to air doesn't work. But it was not echo to air, was not removal CO2. If you look at the numbers, the VCO2 removed was 10, 20, 30, 50 milliliters per kilo, which is definitely not enough to adequately correct the mechanical ventilation and at the end of the story to reach the goal you need. I thank you for the attention.